In this video, we will learn about the fractures and dislocations around the hip joint. The learning objectives are to give an overview of basic anatomy and radiology of proximal femur, understand the basics of intracapsular and intertrochantric fracture neck femur, etiology, management and prevention of proximal femoral fractures, and a note on common hip dislocations and the management. Section 1, let's start with fractures. And before we go to the specifics of fractures and dislocations, let's look at the basic anatomy and radiology of proximal femur. Femoral head articulates with the acetabulum, and other bony landmarks such as the neck, the greater trochanter and the lesser trochanter are marked. The profunda femoris artery supplies the majority of the proximal femur. Its medial circumflex branch passes posterior to the femoral head and anastomoses with the ascending branch of the lateral circumflex femoral artery and forms an arterial ring around the neck of the femur. From this arise the retinacular vessels. They travel subsynovially to reach the head-neck junction and supply the majority of the femoral head. A minor portion of the medial part of the femoral head is supplied by the foveal artery. This arises from the posterior branch of the obturator artery and travel within the ligamentum teres. If the retinacular vessels are disrupted, the foveal artery alone will not be able to sustain enough vascular supply to the femoral head. Coming to the capsular attachment, the anterior capsule is attached to the intertrochantric line and posteriorly it's attached to the intertrochantric crust, which is about a centimeter proximal to the intertrochantric line. Putting all this together, we will look at the fracture anatomy of the proximal femur. An intracapsular fracture neck femur is when the fracture line is between the head-neck junction till the attachment of the hip joint capsule. If the fracture is between the capsular attachment and just proximal to the lesser trochanter, then it's called intertrochantric fracture or an extracapsular fracture neck femur. When the fracture line is just below the lesser trochanter and up to 5 cm distal to it, then it's termed a subtrochantric fracture. Two radiological markers helps us to understand proximal femoral fractures better. The Shenton's line is a curved line that can be traced continuously from the inferomedial border of the neck of the femur to the proximal boundary of the obturator foramen. This line is broken in hip dislocations, fracture neck femurs, and displaced superior pubic ramus fractures. The second one is the primary compressile trabeculi. These are gently curved vertical lines that can be traced from the medial femoral cortex to the head of the femur, and these are continuous with similar lines in the acetabulum. This represents the main weight-bearing part across the hip joint. Now coming to the specific types of fractures in an intracapsular fracture neck femur, the fracture line is between the head-neck junction and the attachment of the capsule. Here the retinacular blood vessels, which are the main vascular supply to the femoral head, are disrupted. This poses a significant risk of avascular necrosis and non-union. In elderly, osteoporosis and fall are the common causes, and in younger population it's usually due to a high velocity trauma. This is the fracture line in intracapsular fracture, and the Shenton's line is marked and it is broken here. And if you look at the deformities, there will usually be a moderate amount of shortening and moderate external rotation of the lower limb. Coming to treatment, in elderly, it's treated by replacing the femoral head with a prosthetic head. In an active elderly individual, total hip replacement would be appropriate. If they have limited mobility, then a hemiarthroplasty should suffice. In younger population where bone preservation is also a priority, internal fixation with cannulated screws or DHS may be tried. If it fails, a total hip replacement may be necessary. The classification systems for intracapsular fracture femur is sometimes a hot favorite of examiners. One way to classify is based on the location of the fracture line. If the fracture line is very close to the head-neck junction, then it's called a subcapital fracture. If the fracture line is in the mid portion of the neck of the femur, then it's called a transcervical fracture. And if the fracture line is at the distal part of the neck, just close to the trochanter, then it's termed a basicervical fracture. Due to the extent of vascular disruption, prognosis is better in basicervical, poorer in subcapital, and intermediate in a transcervical fracture. Intracapsular fracture neck femurs can also be classified based on the disruption of the primary compressile trabeculae, and this is termed the Gordon's classification. Type 1 is impacted or an incomplete fracture. Here, the trabecular pattern are continuous but bent at the fracture level. You can see that the trabeculae at the head acetabular junction are aligned normally. Type 2 fracture is a complete undisplaced fracture. Here, the trabecular pattern are continuous but broken at the fracture level. They are normally aligned at the head acetabular junction. Type 3 is a displaced fracture. However, there will be some contact between the fracture fragments. Here, the trabecular pattern is broken and displaced at the fracture level. They are also malaligned at the head acetabular junction. Finally, type 4 is a fully displaced fracture. Here, there is no contact between the fracture fragments. Here, the trabecular pattern are broken at the fracture level, but they are well aligned at the head acetabular junction. This is because the head is now free to swing within the acetabular cavity and assumes its normal position. Here is a radiograph of an intracapsular fracture neck femur. The lesser trochanter is prominent, indicating an externally rotated leg. It has also proximally migrated, indicating shortening. You can also see the broken shunted line here. A hemiarthroplasty was done for her. The second type of proximal femur fracture is an intertrochantric fracture or an extracapsular fracture. Here, the retinacular blood vessels are well preserved and there is no risk of avascular necrosis or non-union. However, it is a much more painful fracture compared to an intracapsular fracture. In elderly, once again, it is due to osteoporosis or a trivial fall. In young individuals, it's due to a high-velocity trauma. Deformities in intertrochantric fractures are much more exaggerated. There is usually a significant shortening and external rotation. This is termed coxa-vara deformity. Coxa is hip, varus is reduced neck shaft angle. Treatment for all intertrochantric fractures is internal fixation with DHS or dynamic hip screw or a proximal femoral nail. In this X-ray, you can see the fracture line here and a prominent lesser trochanter indicating an externally rotated leg. Let's now look at the key differences between these two types of fractures. In an intracapsular fracture, the fracture line is proximal to the capsular attachment and it is distal in intertrochantric fracture. The vascularity of the head is compromised in intracapsular fractures due to disruption of retinacular vessels. It's not affected in intertrochantric fractures. Due to this, there is a risk of AVN and non-union in intracapsular fractures which are absent in intertrochantric fractures. If you look at the extent of deformity, which is shortening and external rotation, it is moderate in intracapsular fractures and severe in intertrochantric fractures. Now the third variety of proximal femur fracture, the subtrochantric fractures. Here the fracture line is within 5 centimeters from the distal part of the lesser trochanter. Here there are no concerns of vascular compromise to the femoral head, and the usual causes are in young due to a high velocity trauma such as a road traffic accident or fall from a significant height. In elderly, apart from osteoporosis and a trivial fall, it could also be due to a metastatic cancer or bisphosphonate overuse. An intramedullary nail is a standard treatment for a subtrochantric fracture. Here is an X-ray of a lady who was on a long-term bisphosphonate treatment for osteoporosis. Note the fracture line is just distal to the lesser trochanter. Fractures of the proximal femur are aggressively treated because of significant morbidity and mortality risks. Most of the complications can be attributed to pain and immobility. Systemic complications that patients tend to develop are decubitus ulcers, atelectasis, chest infection, paralytic ileus, urosepsis, delirium, DVT and PE, and a host of others. Local complications are non-union in case of an intracapsular fracturic femur, malunion in case of an intertrochantric fracture, joint stiffness, muscle wasting, and osteopenia. Because of these reasons, the basic rules for the treatment of fracturic femur are pain relief, early mobilization, and bone preservation. The standard immediate treatment for these types of fractures are pain relief by appropriate IV analgesics, skin traction, and limb elevation, and basic systemic treatment with IV fluids, oxygenation, and protection of the pressure areas. We should also be monitoring the vitals, input-output, and other parameters. Basic investigations such as X-rays of the affected area and chest X-ray are essential. Basic blood workup and any other associated medical comorbidities should also be investigated. And here again we will quickly go through the treatment protocol for each type of these fractures. In an intracapsular fracturic femur in elderly, we do a prosthetic replacement of the femoral head. If the patient has limited mobility, we do a hemiarthroplasty. And in an active individual, a total hip replacement. If the patient is much younger, then we try to preserve the bone and do a dynamic hip screw or a cannulated screw fixation. However, if the fixation fails, we proceed with a total hip replacement. In case of intertrochantric fracture, the choice is much easier. For all age groups, the standard treatment is a close reduction in internal fixation with a DHS or a PFN. Rarely, an open reduction may be necessary. A subtrochantric fracture is usually treated with an intramedullary nail. The postoperative care and the postoperative complications that may develop in patients with fracturic femur are enumerated here for your reference. Now, a note on the prognosis of proximal femoral fractures in elderly, especially above 80 years. The proximal femoral fractures are serious life-threatening injuries. Even with appropriate treatment, it carries about a 25% mortality rate in the first year after the fracture. Untreated individuals usually succumb to the injury. Intracapsular fractures, younger age and women fare better. Men over 90 years with intertrochantric fracture are unlikely to survive the injury. Compared to the pre-fracture level, the final mobility usually gets downgraded by one level. Outcome is linked to the timing of the surgery. Sooner it is done, the better is the prognosis. Because of these reasons, there has been a lot of emphasis in preventing proximal femoral fractures in elderly. Some of the key points to be noted here are falls prevention, osteoporosis treatment, prophylactic surgery like intramedullary nailing in a metastatic cancer. Falls prevention can be done either by managing the surroundings or managing the medical condition and medications that might predispose to a fall. To prevent and treat osteoporosis, lifestyle changes such as regular exercises, cessation of smoking and alcohol, and to start on an appropriate medication for osteoporosis should be tried. Let's now move to the next section, dislocations around the hip. Traumatic dislocation is further classified into posterior, anterior, and central dislocations depending on the displacement of the femoral head in relation to the acetabulum. Congenital hip dislocation, more appropriately called developmental dysplasia of the hip, is unrelated to trauma and represents a spectrum of developmental anomaly of the acetabulum and proximal femur. I will make a detailed video on this in pediatric section, but for now we will continue with traumatic hip dislocations. Hip joint is a stable and a congruent joint. Traumatic displacement of hip is a serious injury with significant energy transfer. Posterior hip dislocation is the most common type of hip dislocation, and here the femoral head moves posterior to the acetabulum. Clinically, the leg is adducted, shortened, and internally rotated. The usual mechanism of injury in a posterior hip dislocation is a longitudinal force that's applied on a flexed, adducted, and an internally rotated femur. It's like sitting in the front of a car seat, crossing the leg, and involved in a head-on collision, also called a dashboard injury. Fall from height can also lead to posterior hip dislocations. Coming to management, as I mentioned earlier, these are high-velocity injuries and systemic injuries need to be suspected, and the patient is managed according to the advanced trauma life support protocol. Specific management of posterior hip dislocation includes pain relief with appropriate analgesia and local assessment including the sciatic nerve functioning. Suitable X-rays and, if safe, a CT scan is done to assess the dislocation and acetabular fractures, intra-articular fragments, and other injuries. Dislocation is reduced either by closed or open method and is re-evaluated with appropriate radiological investigation. Here is an axial CT view of the hip joint showing left hip posterior dislocation. Note the femoral head is posterior to the acetabulum as shown here. Fracture of the posterior lip of the acetabulum with a small displaced fragment is here. An empty acetabular cavity is marked. Hip dislocation disrupts the retinacular blood vessels, which are key vascular supply to the femoral head, and hence makes it more prone for avascular necrosis. For this, and also to reduce pain, hip dislocation should be treated as an acute emergency. Posterior hip dislocation can be safely reduced in the emergency room or in the operation room, depending on the availability of facilities and trained personnel. The patient is appropriately sedated or anesthetized, placed in a supine position while the assistant stabilizes the pelvis. The surgeon flexes the hip to 90 degrees, moves the leg to slight adduction and internal rotation, and a longitudinal traction is applied firmly to reduce the hip. Skin traction is applied. Check X-rays are taken to confirm the reduction. Three important complications to remember in posterior hip dislocation are sciatic nerve injury, osteoarthritis of the hip, and avascular necrosis of the hip, which can further result in osteoarthritis. In order to reduce the incidence of these complications, we aim at early congruent reduction and fixation of the fracture fragments and retrieval of any loose fragments from the acetabulum. Finally, before we wrap up this video, a quick look at other rare types of hip dislocations. In anterior dislocation, the femoral head lies anterior to the acetabulum and the lesser trochanter is more prominent, indicating that the leg is externally rotated. In central dislocation of hip, more appropriately called central fracture dislocation, there is a fracture in the floor of the acetabulum and the proximal femur migrates medially towards the pelvic cavity. Both the anterior and central dislocations are once again treated along the ATLS protocol, and an early reduction of the dislocation is undertaken. The detailed study of these fractures and dislocations is beyond the scope of undergraduate syllabus. This is the end of this video. Thank you for watching.